Good evening, ladies and gentlemen. Welcome you all to this 28th session of ECG Basic and Beyond. Today, we'll be with some case studies on ECG. We have got three speakers today. We'll start with Professor Dr. Toufiqur Rahman, then Professor Chowdhury Hafizul Hassan, and then Dr. Anisul Awal. Our first speaker is Professor Dr. Toufiqur Rahman. Professor Toufiq is working as Professor of Cardiology in Colonel Malek Medical College, Manikganj. May I request Professor Atahar sir to say a few words about the session and about Professor Toufiq.
Abdul, তুমি আমারে ওই ল্যাপটপটা একটু কানেকশন করে দেবা?
Professor Atahar sir.
Good evening and welcome everybody, and good evening to our dear participants and panelists. Particularly, I have seen Dr. Kanis Fatima, Navin Sheikh, Dr. Professor Khalikud Jaman, Dr. Muqaddas Hussain Sadi, and many others, and also Dr. Mohsin Ahmed is also with us. And first of all, some introduction about Professor Toufiqur Rahman Farooq. Dr. Toufiqur Rahman Farooq is a very brilliant clinician, talented teacher, and academician. He is known for his talent. He has completed his post-graduation at the early age. He has become the professor, now working as the professor of cardiology in Manikganj Medical College. He is not only a clinician and a teacher and interventional cardiologist. Toufiqur Rahman is also known as a good writer, and particularly he has got good number of the books in the field of the cardiology, particularly the ECG and some clinical aspects. So Professor Toufiqur Rahman Farooq is a very, particularly Dr. Chowdhury Hafizul Hassan. I think you are in the screen. Dr. Toufiqur Rahman Farooq, Professor Toufiqur Rahman Farooq is a talented teacher and academician just like you. He is very popular, and I can see Professor Abdul Wadud Chowdhury. Professor Chowdhury, I request you to say something about the Professor Toufiqur Rahman Farooq.
Good evening, everybody, and assalamu alaikum. Actually, I have been lucky enough to be his teacher from the very beginning. In his third year, perhaps his medicine study was started under our tutelage, myself and Professor Saifuddin Akram. And we are lucky enough to be his teacher again during his MD cardiology course. Toufiqur Rahman Farooq is very successful as a physician and also a prolific writer. And I hope today we'll get some glimpse of his expertise and knowledge regarding the clinical cardiology, of which we are very much interested. I was asking him so that he should present ECG, which are usually important for our general practice, not catheter-based practice. Let's hope he will enlighten us with some of the interesting ECGs. Thank you, everybody.
Thank you, sir. Thank you, Professor Abdul Wadud Chowdhury, sir, to have with us. We have got also Professor AQM Reza, sir, with us, and Professor MG Azam with us. Professor Mohsin Hussain is with us, and Dr. Nahruma, Dr. Muqaddas Hussain Sadi, and Dr. Navin Sheikh, all are with us. Now, may I request Professor Toufiqur Rahman to go for his presentation.
Thank you, Firoz Bhai. Thank you, Atahar sir and Abdul Wadud Chowdhury sir for nice talks, nice introduction. And thank you, sir, for inviting me to say something about the ECG, which I will going to present. Though the ECGs are very easy, I think. So my first ECG, a 34-year-old lady presented with palpitations and shortness of breath for the last 4 years. She's a diagnosed case of primary pulmonary hypertension, and her Doppler echocardiography shows PSP 103 millimeter mercury. And she had the following ECG. And what is the diagnosis and the findings of this ECG?
May I request some of our panelists to make some comments on it?
Right.
Toufiq,
Before,
Paul, do you have any question?
Sir, pollটা এবার next time ইনশাআল্লাহ এবার স্যার একটু টাইম কনস্ট্রেন্টের জন্য রেডি করতে পারেনি পরে বার ইনশাআল্লাহ
আচ্ছা মানে what is your question?
What is the
What are
ECG
the
definition?
ECG findings and what is the ECG findings actually?
as he wants to know what is the diagnosis, ECG diagnosis.
ECG diagnosis.
Shomir Paudel, are you here to make a comment? Shomir,
Yes, sir.
do you want to make a comment?
Yes, sir. It's a narrow complex tachycardia. We can see the POFs in some of the QRS complexes, and in some there is no POFs. That means there is frequent APC also. Can we show the EKG? Okay, good.
Toufiq, either you can show or you can tell about the EKG. That is the
Yes, actually, this is a normal ECG, normal complex followed by actually a narrow complex without any P wave actually. And there is a large R wave in the V1.
My question, let's say the first beat almost half visible. Which one is normal complex, which one is not? What do you say?
Yes, normal complex, one is normal followed
So
by
you can
abnormal,
use
and one and followed by abnormal. That is a bigeminy type of ECG.
Atrial bigeminy.
Can you use your
Most likely atrial or supraventricular bigeminy.
Toufiq,
Yes.
you can use your laser or cursor to show the complexes that will help the audience.
Normal you are expecting, and which one is?
This is the normal with PF, and this is the without any PF. This is the complex, and these are followed by any again complex with PF and without PF.
Point is, a gap should be between the abnormal complex and the next normal complex. Is it not a little bit the other way around? That's the interesting point of this ECG. Because after the PSC, you should have a greater RR different distance.
that is the you want the pause,
Yeah. Athar bhai?
Abdul Jamil. Actually,
Sir,
can it be the atrial tachycardia? Sorry, atrial flutter, as because if you see the AVF,
yes,
Lead
I'm
AVF.
thinking of that, sir.
the lead, that is the there are some, I can see the clear, these are the flutter waves, I think. That is the more visible in case of the lead AVF. And please look at the lead V1. There is there are some the P like waves in alternate. There is a P, not P, P, not P like this. So AVF suggests it is atrial flutter. Do you agree, Toufiq?
So atrial flutter, yes sir, maybe.
There is the atrial flutter with variable block. Narrow complex tachycardia and the flutter waves are seen in case of the lead AVF.
Athar bhai, the variable block is not there because
Variable noise, if the alternate
It-
it is
Uh,
variable block to the P waves.
Right.
it's not that it's simple ECG. It's a very interesting ECG.
Yeah.
every alternate has got a P wave. Every alternate.
Oh, that P wave is is a problematic P wave, because if it is PSC, then the abnormal complex should have the next complex should be delayed. Instead, here the RR interval is greater when there is an apparent P wave before that complex. So that could not be.
And another interesting thing is the
P2 itself.
QRS complex that is preceded by P wave is wider than the QRS complexes without P wave.
Yes, yes.
But in case of the lead V1 topic, you see that is
Yes, sir.
after the QRS complex, there the every QRS complex is followed by the flutter waves. There is the lead V1, you see the bottom line. There is every QRS. There is every QRS complex is followed by the flutter waves. So there is the regular flutter waves clearly seen in AVF as well as in the V1.
V1 as well as in V2.
V2 তে ভালো দেখা যায় আতার ভাই।
Yeah, right,
V2 is
also
more conspicuous.
So এটা দেখানো, the most important thing is this ECG. Apparently, it's that's the one point. What are the other findings, Toufiq?
So other findings are that there is a large R wave in the V1, V2, large R wave.
With
That
right,
may suggest there is maybe right ventricular enlargement or right ventricular hypertrophy also.
with right axis deviation. So
With right axis deviation, yeah.
So any other comments? That is let us discuss the ECG. Wadud.
what treatment are you going to give to this patient? Primary pulmonary hypertension, tachycardia, she is in distress. Which anti-arrhythmic drug you are going to choose?
That is, this patient has got the atrial, that is supraventricular tachyarrhythmia with the structural heart disease. We have to select the drug on this basis. That is, the patient has got the supraventricular tachycardia as well as the structural heart disease, because the patient has got the primary pulmonary hypertension, severe pulmonary hypertension, so structural heart disease. So what are the choice of the drugs?
I would prefer
Anti-arrhythmic drug.
limiting one.
Sorry?
I would prefer a rate limiting calcium channel blocker.
Chowdhury Hafiz.
The EKG, if you look at the V1, V2, I don't have the measuring thing, but looks like that there is sinus and then there is a PAC complexes. Why I'm saying sinus, because although there is no pause, and we'll have to give an explanation, but if it is atrial flutter, because it is very consistent that a long RR, then short RR, long RR, short RR. But if it is atrial flutter or atrial tachycardia with 2:1, then that doesn't fit in. But then it will be same RR interval. So looks like sinus stack with the atrial bigeminy. That's probably most likely, I will say. Now the explanation, is it a separate focus at this? Therefore, we are not seeing the pause. I don't know. But there is a right ventricular hypertrophy and pulmonary hypertension, and how you treat this. I'll wait for that. But this is a bad situation. Before we do that, we also need to know what is the patient's systemic blood pressure.
Yes.
And what is the pulse ox?
Sir, Atahar sir, regarding the ECG, is it possible that one beat has got a sinus wave with normal PR interval followed by a sinus beat but prolonged PR interval? At least in lead one, it looks like that over the T wave, there is a P wave. So the one with shorter PR interval, another one is longer PR interval. Is it possible? Because it doesn't fit with atrial ectopic or ventricular ectopic. And I'm not sure whether it is atrial flutter, because there is a definite rhythm
No,
as
these are all
Officer
actually.
was.
So these are all the points we have to consider, and these are the differential diagnosis. And uh, the message to our participants should be clear. As for example, this is the narrow complex irregular trachycardia. The irregular in the format that is not
Regular.
totally irregularly irregular. That is the long, short like this. And this is the narrow complex trachycardia. So atrial flutter, sinus tract with atrial biseminy, and atrial tachycardia, all are the differential diagnosis. And this is the message to our participants. That is all these are the diagnosis. And what are the possibilities? What should be the first possibilities? We have got some points in favor of the atrial flutter, and Chowdhury Hafiz has told that it could be the sinus tachycardia. So these are all the points you have to take consider. And from the ECG, it is difficult to give the single most diagnosis from this ECG because if it are the regular, fairly regular, the first point should be the atrial flutter, but it is not the regular. So this is against the atrial flutter, but we can see some of the flutter waves. So Dhuri?
Atahar bhai, one thing is that very interesting. All the look at V2. All the apparent P waves are similar. So if
Yes.
we see P wave should not look like the normal sinus P wave. But all the waves, the apparent P waves are similar looking. But PR interval is variable.
PR
Actually, if you look at the PR interval, then in the PR interval for the if in the sinus bit is same, the PR is not. PR is when there is a P, the PR interval actually is fixed.
But the normal ectopic P wave is also similar looking to sinus P wave. That's the problem.
Chowdhury Hafiz.
Yeah.
One thing, I think it
Okay,
is
so
more,
one other thing that you can do is what is the EKG after we slowing this heart rate? What happens?
Do you have any ECG when she?
No, sir. No, sir.
Oh, that.
but again, I want to Chowdhury Hafiz. Actually, if you look at the lead V1,
Yeah.
what we are telling about the atrial premature complex, that is PSC, that is the pause before the ectopic is longer than the pause after the ectopic. That should not be in case of the ectopic.
Yeah, well, that is the problem.
Again, the point.
That is the problem for explanation. But
right.
Observation is one thing. We cannot come up with the explanation.
Right. So I think the more consistent. But you see at the bottom, that is the lead V1. That is the flutter wave complex, flutter wave gap complex, flutter wave complex.
Unless there is an atrial focus that is intercalated.
So I think this is more.
Like a parasystole type when there is a sinus rhythm firing, and then there is something else automaticity. The mechanism is probably atrial automaticity here.
Most likely.
Again, it can
Atahar
be
atrial
flutter. That is 1:1 atrial flutter. That is 1:1, 2:1, 1:1, 2:1, like this. Atrial flutter means like this. That is
Atahar bhai,
please.
হ্যাঁ Atahar bhai, sorry, আমি আরেকটু মানে অ্যাড করতে যাচ্ছি এখানে যে if you look at lead 2 and lead V2, these two lead, there is short PR interval, and also there is a delta wave like structure. Lead 2 and V2. PR interval is very short, and there is also a delta wave.
Complex. So could it be the second complex is sinus and third one is a fusion one with atrial ectopic with aberrant conduction? The second one is P followed by QRS, and third one is P with aberrant conduction, a junctional P with aberrant conduction like this.
So what is the diagnosis, Professor Reza?
I cannot tell this. It's a very tricky ECG.
Tricky ECG. Now, I think more consistent with the atrial flutter with alternate 1:1 and 2:1 block. That is atrial flutter with 1:1 and 2:1. 1:1, 2:1.
So can I say something, sir?
Yes, Mohsin, welcome.
Sir, I think this is a case of, sir, atrial tachycardia, sir. Yeah? Because atrial flutter, the rate would be with 1:1. It is very unlikely. But in atrial tachycardia, most likely fit like this. As the pressure.
Firoz,
So,
there is no ECG on the screen.
you know, I'm not an EP guy. We can hear all day to go through the differential, but we all agree that this is a atrial arrhythmia, and the patient is tachycardic, and the patient has a bigger problem, pulmonary hypertension with right heart problem. And how to manage this patient? If we can slow down the heart rate, we can see this. If not, we can hear from the EP guys that when they study the rhythm, they can analyze. There may be few explanations, but my bigger problem is that what we do with the, and we need also an assessment that from the echo, just the RVSP is high, and is there any other abnormality? Anybody wants to know any other abnormalities that can be relevant?
Firoz, is the ECG on the screen?
No, sir. ECG is not on the screen, sir.
Toufiq?
Dr. Toufiq has got some problem with his net connection. He's coming back, sir. Sir, regarding the treatment purpose,
No,
what should be
before-
done? What anti-arrhythmic drug should be
And
given?
we need to look at the echo thoroughly, because what we
Dr. Tushar, please mute yourself.
Now, Firoz,
Sir,
now before that, we have to give a clean-cut message to our participant. That is what was the diagnosis of the ECG. So, what is Chowdhury Hafiz has already told, this is the atrial tachyarrhythmias, supraventricular tachycardias, and the differential are the atrial flutter, atrial tachycardia, or the sinus tachycardia with atrial byzobeny. Am I correct?
yes, sir. Yes,
So
sir.
this is the message to our participants. So come to the point, that is the, and final diagnosis will be at the EP lab. Am I correct, Chowdhury Hafiz?
yes, that's exactly I wanted to say.
So now come to the management part. Professor Chowdhury Wadud.
The point is, as Hafiz Bhai was saying, if the systemic pressure is quite all right, I would go for a calcium channel blocker. If the systemic pressure is low, then I would go for an amiodarone.
Will you consider beta blocker, sir?
The patient has primary pulmonary hypertension. I would prefer a rate-limiting calcium channel blocker.
What is your comment about?
With that pulmonary pressure, there is every chance that this patient will have got RV dysfunction. With that RV dysfunction, will you go for a calcium channel blocker?
That's the point. That's why you have to have the whole information. And in that case, the safest drug perhaps is what is in this country is amiodarone.
There's a joke about amiodarone. If you use amiodarone, you don't need an EP.
And, yeah.
That's why the EP guys, they hate amiodarone. But it is a good bailout drug.
Very true.
True. Toufiq is disconnected.
So
Right. Sir, please.
the how old is this patient?
34.
Yeah. So and female, right?
Yes, sir.
And Chowdhury Hafiz, the patient has got the acute symptom, that is shortness of the breath. Is there an indication of the DC shock?
Well, any tachyarrhythmias, if the patient has hemodynamically unstable, you can give a DC shock, but that's probably the least of an issue. But if the patient does not have hypotension and is still having this, and then we need to give pharmacological therapy. Now, the other thing is the RV is going to be big dilated, And if it is that, and then the RA pressure is high, we need to assess what we can give to help the RV. That's a very bigger problem, because as I tell always that when the RV goes down, whole cardiology goes down. When the blood pressure is low, the BP is low, and PP is going to be bad. That means renal failure and hemodynamic crisis. But when the RV goes down, whole thing goes down. So in this case, it is very important to do the whole hemodynamics. What is if possible, to even see that if the patient is systemically still maintaining pressure or not. Because when the RV failed with the low systemic blood pressure, then you have to give the RV support. Otherwise, the patient will not tolerate this. And with this pressure, there is another compounding problem happens. Sometimes they open up a PFO, or there is a coexistent ASD, and patient may develop cyanosis with the right to left shunt now, maybe even bigger problem. So we need to control the rate. There are many drugs we can give. Digoxin, old friend, is not a bad thing, but it may take a little longer time. But the bigger problem is when you give calcium channel blocker like diltiazem or verapamil, not only we can deteriorate the situation and patient may go into hypotensive, then we may lose the whole thing. So this is a very tricky situation that we are in.
We have seen patient who has very severe pulmonary hypertension with very good RV function.
Yes, that is actually the case. That is the RV dilated, but still having good systolic. You can do TAPSE, you can assess the visually what the RV function is, RV systolic function. Now, if you take to the hemodynamic lab, you will get even better sense. But acutely, that may not be possible. So we need to do the echo assessment much better, and then see what the patient can tolerate. Therefore, I would not jump. I would assess whether there is any ASD or PFO, or how is the LV function, any left-sided issue. There is no left-sided issue, then you can choose either DIG or amiodarone, probably. But this is, again, EP guys are against it, but amiodarone here is not for long term. If you're using it, it is for very short term. But then question is what we do after that. I don't know what happened. And can you give us a follow-up?
Toufiq, do we have any follow-up of this patient?
No, sir, no, not at this moment.
Okay.
And generally speaking, the pulmonary hypertension is a sort of subject that we understand less. We need to, it is possible that this will be a WHO group 1, but it is important to know the workup, how you do a workup in a young patient like this. Is it like a chronic thromboembolism? Acute does not give this picture. Then is there any interstitial lung disease, parenchymal lung disease, or there is any other, the other things is any connective tissue disease, scleroderma, HIV. All these are important to delineate. Usually the portopulmonary hypertension, usually they don't give this high pulmonary hypertension, but it's kind of interesting. And overall, if this is a chronic thromboembolism, which is not unusual to see this kind of thing, the ideal test is VQ, and then sometimes they respond very well with end arterectomy.
Thank you, sir. Toufiq, you can proceed for the next slide.
Do you think CTPA has any role in it? CT pulmonary?
We need to define this better. That what is the etiology and what we need to do. Yes.
Toufiq, you tell us about the whole thing. Nah, the RVH and other things, please. Recite those things. Toufiq,
Yes. It's there just for recapitulations. There are causes of dominant ROB in V1. the normal in children and young adults. There may be right ventricular hypertrophy. It may be due to pulmonary embolus or persistence of infantile pattern or left to right shunt. It may be due to right bundle branch block or posterior mitral infarctions, WBW syndrome, especially type A. And there may be incorrect lead placement, dextrocardia, and hypertrophic cardiomyopathy. There are some diagnostic criteria of right ventricular hypertrophy. The right axis deviation of more than 110 degree, dominant ROB in V1, more than 7 millimeter tall or RS ratio more than 1, dominant SOB in V5 or V6 more than 7 millimeter deep or S ratio less than 1, and QRS duration less than 120 milliseconds. That is, it seems that change not be due to right bundle branch block. And there may be some supporting criteria like right atrial enlargement, maybe P pulmonary may be present. There may right ventricular stent pattern may be seen, and there may be deep SOB in the lateral leads also. And a right bundle branch block may be present either in the complete or incomplete form. Second ECG. A 34-year-old gentleman presented with severe upper abdominal pain with vomiting for 4 days. He was diagnosed as a case of acute pancreatitis.
Can I interrupt you for a second? So what happened to this patient? Any follow-up? No follow-up?
No, actually, I don't have any follow-up now.
Okay. It was a in-hospital or outpatient?
Actually, this is collected from an outdoor patient.
I see.
ECG and data from outdoor patient.
Okay.
And this patient was referred to actually another hospital for better management.
I asked the faculty, whenever you get such a beautiful ECG, interesting ECG, keep track of the patient and enlighten us again. That will be very interesting for us.
Toufiq, you can proceed.
Toufiq, proceed.
Okay, he was diagnosed as a case of acute pancreatitis. His serum calcium level was 2 millimole per liter, and he had the following ECG. So what is the findings and diagnosis of this ECG? Very simple one.
Toufiq,
Sir?
it is the regular sinus rhythm. I can see just some non-specific STT changes.
Yes, sir. Probably QT interval is prolonged here.
QT.
So actually, this is a,
show the ECG again, Toufiq.
yes.
Apparently, QT is normal.
Yes.
It's less than half of the RR interval. So it's not prolonged.
Achha, Toufiq, did this patient have any tachy or bradyarrhythmias? Any arrhythmias, this patient?
And no, sir.
The point is for the audience.
Only thing is that the T waves are relatively flattened.
Toufiq, the question.
Usual normal T wave.
Sir?
The question I'll be asking is what is the albumin level? We have to have the corrected calcium level.
Yeah.
And then we should look at the ECG to find out if there is any QT prolongation. Whenever you have low calcium, there is a chance of QT prolongation that induces some sort of major ventricular arrhythmia, particularly torsa. That's the point of
yes, sir. When there is severe hypocalcemia, actually.
Is there Professor Khaliquজ্জামান? Khaliquজ্জামান, can you hear me?
Khaled Mosid bhai ase.
Yes.
I do want to comment.
Acha, Khalid bhai.
Yes, Atahar
You are master on QT interval. Just comment.
Kaji Tariqul Islam. No, I don't find any significant abnormality in the QT interval in this patient.
QT interval is normal.
To be honest, there is no obvious change. If you measure it, the rule of thumb, it defies the rule of thumb of prolonged QT interval. But yes, if you measure, but it is not very obvious, I think. Very subtle, maybe.
I want to add something that in the lower panel, the lead 2 rhythm strip, there are some U waves that confuses with the prolongation of QT interval. There are some U waves that might be calculated by the computer as a prolonged QT interval. Often it does. So to me, it's a normal ECG. Only thing is that the T waves relatively flatter than the normal usual QRS complex. Otherwise, it's normal ECG.
Yes, sir. It is around 320 to 350 milliseconds.
And what Professor Wadud has said that regarding the albumin level, it is very important in this case because in patients with acute and chronic pancreatitis, they are likely to have some malabsorption syndrome, and that might have led to hypoalbuminemia, or maybe there is some renal dysfunction as well. So it's a very important implication, actually.
Whether the albumin level has got relation with the calcium level also.
Yes, the corrected, definitely corrected albumin calcium level is correlates with the albumin level.
For the audience, if you have low albumin, the calcium level as measured will be a little bit low. If you it, then the calcium level will be a little bit higher. Then that will be nearly normal. So if you think this is a very severe hypocalcemia, it may not be actually very severe hypocalcemia. That's the point we are insisting. And the most thing that any pancreatitis patient should have his or her calcium measured along with albumin, and then the ECG should be taken care of.
And drawing blood for calcium level is also very important. Actually, the calcium, the tourniquet should not be used while drawing blood for serum calcium.
So in the exam, when they give a hypocalcemia, the typical is that long QT and the T is little further than usual. So and there is a T inversion association. So in the exam purposes, it has to be obvious and agreed by clinicians. Then they give it in the exam. I don't think that this one is something I would buy as a long QT for hypocalcemia.
Exactly.
Exactly.
Well, Toufiq, you can proceed. Next slide.
The computer measured is about 460 millisecond QTC.
Okay, that's one other thing is that is it the corrected one or the computer
Corrected
is
one,
very
sir.
bad.
Corrected one.
Yeah, computer is
QTC,
very bad.
Corrected one.
Yeah, computer is very bad about morphology, but computer is good with the intervals. And the other thing is that if it is 460 or less, probably, if we miss it, we are okay. But if it is 500 or more, we should not miss.
Yes. So what are the ECG changes in hypocalcemia? There may be QTC prolongation, primarily by prolonging the ST segment. The T wave is typically left unchanged, and dysarrhythmia are uncommon, although atrial fibrillation has been reported. Torso the power may occur, but is much less than the with hypokalemia or hypomagnesemia. This is the another ECG. A 29-year-old gentleman presented with palpitations on exertion. He is normotensive. His echocardiography showed hypertrophy of the apical segment of the left ventricle. He had the following ECG. ECG showing Lars, sorry.
Whether the patient had got any history of the tachyarrhythmias?
No, sir. This patient has got no history of tachyarrhythmias. Just is a chamber patient, sir. And the echocardiogram shows apical segment of the left ventricle, and this is his ECG.
What is your comment on the P wave and PR interval, Toufiq?
So PR interval, that's normal here. PR interval normal, P wave normal.
The lead one shows some slurring of the PR interval and looks like the delta also the V6.
Sir, but in V1 or V2, there is no slurring or no PR interval is normal. V1, V2, V3.
And lead 2 and lead 3 shows the bifid P waves.
Bradycardia.
So this is an interesting EKG. So yeah, go ahead, Wadud.
LVH, the patient have also left atrial enlargement as shown in lead 2. And the T wave.
There is a, yes, sir, P wave is lost.
But the bigger issue is the hypertrophy. He's a 29-year-old.
Left ventricular hypertrophy.
With the hypertrophy, and then they look at the T morphology. So the question is,
hypertrophy is more in the apical legs, 3, 4.
Yeah. So this could be in a apical variety of the familial cardiomyopathy.
Yes.
And then palpitation can be a big issue because this can be related to VT.
Hafiz bhai, the whole HCM patient with apical hypertrophy, they have less chance of VT, isn't it?
They have what?
The hypertrophic cardiomyopathy patient with apical variety, they have less chance of VT.
Yeah, except one issues. And I have a couple, actually one is a nurse. So in the apical variety, sometimes the apical hypertrophy is such that in the very apex, there is an obstruction, and then the apex becomes thin. It becomes like an aneurysm type. And that can be a source for VT, that's why you need to be careful. And in those cases, we actually give ICD for protection. And you also do the usual thing from the Elliott's paper from London, the famous, non-sustained VT, the thickness, then the family history of syncope and all that criteria, and along with the gene mutation. There are 5-6 criteria, that we look for giving is, but apical variety, we need to think about this, that whether this is giving any apical aneurysm or not. And this is part of the apical cardiomyopathies. And interesting. I don't know what was the further follow-up on this patient.
Okay.
So was the patient getting any beta blocker because she has bradycardia? That patient, that person has bradycardia. Toufiq.
And I would also warn everyone that when you see this kind of thing with the biphasic T, and this becomes a problem in the emergency room, the patient comes in with chest pains, atypical or typical, doesn't matter, and then they call it a STEMI. In the presence of LVH, I think the Wallenstein interpretation as acute coronary syndrome is less sensitive.
Sir,
less specific.
Rafiq sir has joined.
Rafiq sir has joined. Toufiq.
Toufiq is lost.
Sir, গাড়ি মধ্যে।
Sir,
আমি ড্রাইভ করতেছি।
Okay, sir. আচ্ছা, Chowdhury, Wadud Chowdhury.
Sir.
This ECG for our participant, if is in the examination hall, what will be the diagnosis? Whether the student will give the differential diagnosis of the hypertrophy or directly will tell the cardiomyopathy, it is hypertrophic cardiomyopathy. What is the answer you want to?
The ECG diagnosis, and they give the possibilities like that. They should not say hypertrophic cardiomyopathy because hypertrophic cardiomyopathy is not ECG diagnosis. LVH is ECG diagnosis.
Correct.
Yes.
Is there any special clue, Toufiq, for the first consideration of the hypertrophic cardiomyopathy? Is there any ECG clue from which you can consider that this is the ECG of the hypertrophic cardiomyopathy?
Our so-called Aniswise sign.
Yes. Yes.
Aniswise sign is good.
Toufiq, do you know it?
Dr. Toufiq has got some problem with internet.
Okay.
Probably he will
Cardiac sign
not be able
is
to continue the
So
very
I wanted
interesting.
to differ a little bit with Wadud about the students answering this. So, you know, the hypertrophy is there, and the ECG can be so characteristic that you probably need to give a differential, but put the apical variety cardiomyopathy first. Now, what else can be possible in this patient? This patient can have, you know, hypertensive hypertrophic cardiomyopathy,
Yes.
and 29-year-old with hypertensive hypertrophic, then you need to look for other causes like bicuspid valve, and then you know, the hypertension because of the renal artery stenosis, or you know, hypertension diagnosed secondary at early onset, and then get the hypertrophy following that. Surely bicuspid congenital valve can give you hypertrophy like this, but that is differential. But if there is no clue in the exam finding, and the blood pressure is normal, that means this is hypertrophy without an increase in the afterload. So without hypertrophy, without an increase in the afterload in this population, this is almost certainly a familial hypertrophic cardiomyopathy.
Yes, yes, I agree.
Thank you, sir. We lost Dr. Toufiq because of net problem. I think we should go with the presentation of Chowdhury Hassan sir. Hassan sir, have you got anything to show us today?
I need to go to my, I'm doing this with my phone. Let me go to my, can Anis,
Okay.
Dr. Professor Awal can go first, and let me log in from my computer.
Okay.
Anis,
Dr. Anis, you have got some presentation to show?
Anis?
Anis Awal.
Sir, you can you
hear me?
Yes, sir.
Yes, sir.
Yes, sir.
So I think one of the thing that pertains to more to us teachers than the learners is what is our expectation from the ECG. We should not. There are a few things that can be diagnosed definitely, more or less definitively from the ECG. If somebody has SVT or VT or acute MI. So as Hafiz mentioned, we should teach our young doctors to come to differential diagnosis, and also for us to accept that we should not demand a diagnosis in a clinical diagnosis from ECG.
Thank you, sir. This is the message to our participant, really. Thank you, sir.
Anis, Dr. Anis.
Firoz bhai,
Yes.
I should have the option to share. I don't have the option to share here.
Yeah, Ripu, ask Ripu to make him panelist.
And can come back again. That will take it.
Acha, whether he's panel.
So I'm glad actually Rafiq bhai is there, because I have an EKG that I have no intention to make any comment. I need Atahar bhai and Rafiq bhai, bona fide EP docs. So I'm glad that Atahar bhai is there and Rafiq bhai has joined. I don't know anything about EP, but I'll show you the EKG because a question came in.
You can go with Hafiz sir, and then you
Okay,
can.
so let me see whether I can share.
Hafiz sir, you go with your presentation.
Okay,
and
so
Anis will come back.
Can you see my?
Yes, sir, it's coming.
Yes, sir. We can
Yes,
see
you.
you.
Yes, I think I'm getting better. So, okay, so 76. I start with a simple one. 76-year-old male admitted in neurosurgical ICU. 76-year-old coming. This is not like challenging you, but giving you the information as simple. Neurosurgical ICU, troponin 4. Now, look at the EKG. What is your next move in terms of what do you think about this EKG? This EKG suggests significant ischemia in the LAD territory. This EKG suggests long QT and not LAD ischemia. This EKG, anterior wall STEMI, consider immediate revascularization. This is acute coronary syndrome. Start Dept, dual antiplatelet, heparin, and echo, and then consider cardiac cath. This
Can you repeat the
76, yeah, poll, 76-year, look at the top line. In the EKG exam here, the top line is very important. 76-year-old admitted in neurosurgical ICU. Troponin is 4,000 with the high sensitive troponin, which is divided by 1,000 is 4, small. Okay, let's see. And then any comment from the faculty.
Revu, give the poll.
Yes, sir, starting the poll. So should we go for 30 seconds?
Yes.
Okay.
As Hafiz was saying, elderly male admitted in neurosurgical unit, troponin slightly raised. These are the clues that we should be paying attention to.
And Wadud, I was furious in the morning because I know they are answering the question, because the patient was started on heparin and Dept.
That's
so,
but it should not be. That's the point.
Yeah, so 4 of you actually answered. I would encourage you, because no one is checking your answer. Even if you're wrong, answer it. So in cardiology, we decide, and we need to learn how to decide whether right or wrong. One day you will getting more correct answers. But this is important. Look at the long, this is, I think one of our faculty mentioned very nicely that earlier, that if you see the long QT is more than half, then it is long QT. And often with these giant T waves, you see long QT. And in the neurosurgical unit, this is almost certainly suggestive of a the intracranial event. In this case, it was not just stroke, it was actually an intracranial bleed. And people got worried about the troponin. You will be doing harm if you are not aware. So it is very important. And this EKG should not be interpreted as like a STEMI. And the ischemia,
Okay, can I ask a question?
Yeah.
Why not? I'm just being David's advocate. I know what this ECG is about. I have a theory about it, but there is ST elevation from V1 through V5. And why shouldn't I consider acute MI, anterolateral, almost anterolateral? Why not?
Yeah. So I would, first of all, before I give an answer, there is a excellent review on this issue about 2 weeks ago, came out in JACC about the stroke and intracranial event and the EKG changes, because they summarized why it should not be, because when there is in the presence of a neuro event, the EKG can be mimicking as ST elevation. It can mimic as deep T inversions. So in that cases, before we call it STEMI, EKG wise, Rafiq Bhai is right. The observation, there is one is observation, the other one is interpretation, and the third level is the management. So observation is there. Yes, there is ST elevation in the precordial STs, but in the setting of the clinical, this should not be interpreted as the STEMI. This EKG.
No, I have.
Yeah.
Hafiz.
Yeah.
There is a problem with this ECG, a major problem. Look at the transition.
Yeah.
The transition is between V5 and V6.
Okay.
In V5, there is no R wave, and V6, there is a beautiful R wave. What I think they did, it's a neurosurgical unit, they did not put the leads right.
Yeah, possible. Because it doesn't make sense.
It doesn't make sense. The EKG does not make sense at all. So V1 through V5, I think these were put very close to each other for whatever reason.
Right.
And that probably is confusing the whole issue.
But the question is, the V6 is believable, but there is some ST elevation in the V6. And if you look at lead AVL, there is some ST elevations. And this is the same thing. And this Jack paper tells us very nicely. We now learn that some pathways can give you myocardial injury without any significant stenosis. And one of the pathway is the adrenaline pathway, hyperadrenaline surge, like Takasubu we learned. And in the COVID time, we also have learned that it could be inflammatory pathway, cytokine surge. There are other pathways that people are claiming, which is not well established yet, which is the serotonin pathway, high serotonin surge. And in the clinical context, these are very important to recognize, because in the COVID time, we have learned that in the hyperinflammatory surge and Takasubu picture, we can be fooled and patient may get unnecessary and harmful lytics or cath. These are the patients where you can be very helpful with a echocardiogram with the apical ballooning picture, and you may avoid further harmful drugs.
And Hafiz Bhai,
Yeah.
I want to add that any patient becoming unconscious or having a focal neurological deficit sign should not have any lytics or antithrombotics put in without a CT scan of brain.
I totally agree with you, and this is very important that if it is acute MI, no, I tell the fellows that acute MI does not give altered mentation unless there is a cardiac arrest, or there is a significant hypoxia, hemodynamic embarrassment. That gives you the hypoperfusion in the brain to give you this. MI alone, it does not give you altered mentation. There is one other cause, which is that it may be a late presentation MI and there is LV thrombus and there is a stroke from that. But that usually delayed in the elderly. We see that there is a two problem, MI and the problem with the stroke. Otherwise, you need to be very careful. Now, this one is relatively easy. 37-year-old African-American male following motor vehicle accident and severe chest pain, blood pressure 90/60. Now, this EKG is, and trust me, I will take two answers right from this one because we had trouble among ourselves. But this was last week. A flutter, anterior STEMI, no lytics, will proceed with primary PCI, sinus tachycardia, anterior STEMI, lytics, sinus tachycardia, echo analgesia, immediate TE and cardioversion. "37-year-old African-American male following motor vehicle accident and severe chest pain." I'm expecting 80% right on this one. What is your thought, Atahar bhai or Wadud? I think it is 80%.
Whenever there is a problem with the ST segment, always look at the AVR.
Okay, so not bad, 54. We need more answers. Okay, so any comment from the faculty?
I was saying, whenever you have a problem with ST segment, always have a very clear look at the AVR.
Yes.
That will give you some clues.
Yeah.
There is ST elevation in multiple leads.
Yeah.
Not follow a single arterial dominion.
Yeah.
And given the situation, motor vehicle accident, there is likely that there is chest trauma, and that can lead to cardiac contusion, pericardial injury, pericarditis, and everything.
Yeah. So I usually tell the ER resident that God is not that unkind to give you a STEMI in 3 major arterial territory at the same time. So, and what about the rhythm, Rafiq bhai? Do you buy it as a sinus stack, or you call it atrial flutter, or whatever you want to call it?
Well, I mean, I'm driving, so I can't really clearly.
Atahar bhai?
But if you look at
Hafiz bhai, it looks like flutter.
Yes.
So that's why I said I will take both answers, sinus stack, and so this was after the slowing down.
No, Hafiz bhai.
Okay, now
Yeah.
just stay there.
Yeah, Rafiq bhai.
This one, if you look in AVR, you may make a point of 2p wave before each QRS.
Right,
Right.
sir.
Yes, sir.
And then you have to then put a caliper to see if there is one in the middle.
Yes.
So that's a
It
possibility.
exactly matches, Rafiq bhai. It exactly matches, and the rate of the atrial rate is above 300. So if it is
Okay.
EP, yeah, Rafiq bhai.
Yeah. One of the things is that people may argue in AVR that maybe that's the end of the T wave, but that looks like the one P wave before that. So that is the way. I mean, you cannot 100% guarantee it that it's not an end of the T wave, but if you put a caliper and you can multiple it, then it's most likely what Hafiz is telling diagnosis is.
Yeah. And then the simple way, non-EP way, if the atrial rate is above 300, then we are in the flutter zone, right?
So Hafiz bhai,
Yeah.
so for our participants, for our students and examination purpose, in this situation where the two PFs are clearly seen in case of the lead 2 as well as AVR, whether we should consider the sinus stack as answer.
I told you that I would take sinus stack and atrial flutter both as an answer.
Yeah.
But the reason I put C, because after all these argument that I had, our EP guy said this is sinus stack. Looking at this EKG, I don't know he can say that, but that was the final diagnosis. This is sinus stack with acute pericarditis. But this was when he, the other point he made is that if you look at the, and I don't know, everybody will buy that the P wave in the lead 2 did not become like a sawtooth, and the it did not, it still followed the, the TP segment, and there was no biphasic type in the P wave. I don't know how sensitive or specific that argument is, but this was the sinus tachycardia. Clearly no question about this one. But when his rate went up further, was he maintaining sinus stack or atrial flutter? I don't know. But he briefly stayed there and then came to sinus stack. But we'll have to agree that this is pericarditis, and 37-year-old, with the motor vehicle accident, we should be very careful about further assessment and not bogged down with the STEMI activation, because this was another STEMI activation. Okay, so this was the EKG that I want the EP advisor for Rafiq bhai. 42-year-old bus driver with palpitation. So LVH for possible familial hypertrophic cardiomyopathy because of the LVH, sinus incomplete right bundle, do ETT, pre-excitation is further, pre-excitation needs EP. So let's see. I hope at least we get 20 response.
I like to request participant to answer is because
It's okay to answer. Nobody is following scorecard. Rafiq bhai, who is driving?
I'm driving.
C
Living dangerous life, right?
and D. 18.
Very true.
Okay, so I think not bad. 55 plus 27, which is about 90%, right? 80% right.
7%.
Yeah, so I think we got this, that this is pre-excitation, which is very good. Question is, what do you do with this patient?
No, before that,
I am in favor of ablation, as the person is dealing with the lot of people's life.
no, Hafiz bhai. I said for our participants and for our participants, actually, what is the criteria of diagnosis of LVS in presence of the pre-excitation?
It should not.
Null and void.
Yes.
You should not.
So that is exactly correct. So we don't look at that at all. And then this EKG, we should not interpret that as right bundle and do ETT. And as you know that when we do ETT, we do for two purposes. One is the interpretation of the ST segment for ischemia and to look for any arrhythmias. But here there is the short PR and pre-excitation delta wave present. And the controversy is that what you do with this since he's a bus driver. So, Rafiq bhai?
Well, two things. One, for the audience, pre-excitation, short PR, delta wave, but another characteristic finding this patient has in lead 2-3 AVF, that the delta wave is QRS is coming out of the P wave. It does not go to the baseline. That is the key finding in WPW syndrome, I mean, Wolff-Parkinson-White syndrome. And this patient has that. Now, this patient is, as Jamil said, that truck driver and has palpitation, definitely needs an EP study. And then based on inducibility, get an ablation. The problem will be, you can have somebody with pre-excitation, but palpitation for a totally different cause. So but definitely needs an electrophysiology study for this patient.
And only reason I'm showing you this slide is because as interventionalist, you need to know this. And I tell you why. Because you work with unless there is a dedicated EP lab, you share the cath lab with the EP guys. And if they tell you, I have a patient for ablation, you need to quickly see whether it is a likely left-sided pathway or right-sided pathway. Then, because it takes time. So I usually don't give away the lab. I rather do my coronaries and go home early rather than wait for my case for their ablation. This is my way of looking at the algorithm. But Rafiq bhai, you can go elaborate further if you want to say something, how to differentiate the pathway, the left or right-sided pathway.
No, I don't think in this forum we need to do that, as long as we can diagnose pre-excitation.
Okay.
Yeah,
Okay.
I think that's good enough for us.
But
if we can tell right or left side, that will be great.
Yes.
And that is looking at the delta wave in lead V1.
Yes.
And that will give us. So just quickly understanding. I think if we go beyond that, it becomes too deep, but make sure that we diagnose pre-excitation.
Yeah. And those who have interest, you can always go online and find there's algorithm, and that's a pretty good available resources. So this will be my last one.
One good point about algorithm, before we used to memorize algorithm, but nowadays with internet, it's so convenient that you can, as long as you know where to find it, or take a picture and put it in your iPhone and just go back. You don't have to memorize it anymore.
And I tell you one thing I have done, bioprosthetic valve, how to evaluate. I put this on the wall in the echo reading room so that you can quickly look at this. And then accessory pathway, this is in the cath lab. Then coronary anatomy, anomalous coronary, I put it in the wall. So there is a ready reference. So something you can think about, So this is a 35-year-old COPD, asthma, palpitation, and systolic murmur at the left second intercostal space. So the diagnosis is left second intercostal space systolic murmur. One of the things that they do in cardiology board here, that they give a very good physical exam to correlate with the EKG, and they actually teach a lot when they set up the exam. Okay, so anyone want to comment? So
I'm just curious why so many people choose pulmonary hypertension.
The patient have RBVP. RVH, evidence of RVH is not there. But the thing is...
But I'm just curious. I want to understand the psychology behind it. Pulmonary hypertension is a rare, it's not rare, but it's a difficult disease to diagnose by any means. And if I am choosing as the first choice, I would not choose pulmonary hypertension unless Hafiz put it in red, right?
yes. So the diagnosis is not pulmonary hypertension, and that was a mistake that I put the color. When I did the color, the A became colored as well. But this is the problem I see. The residents and the fellows, they actually like pulmonary hypertension first. Let me put it backward a little bit. So this pulmonary hypertension can give you systolic murmur in the left parasternal, left intercostal. How about ASD? So this EKG, I mean, look at the trick of the exam. The C and D is out because C and D cannot explain the murmur. The examiner is asking for murmur. So either ASD or pulmonary hypertension. Now, the challenge here is if it is pulmonary hypertension enough that you call it right ventricular hypertrophy. If you cannot call right ventricular hypertrophy, then why you are going for pulmonary hypertension? It does not meet, this is a challenge in the presence of right bundle, because the V1, V2, V3, this is clearly right bundle. In the presence of right bundle, can you read right ventricular hypertrophy? Answer is yes. And the voltage should be higher. And then you should have evidence of right ventricular hypertrophy reflected by right axis deviation, which is absent here. So then the question is, what is the best fit? Can ASD fit in? Sure. Right bundle, left axis, ASD, particularly ostium primum, but we don't need to know too much. And then ASD can give you systolic murmur. So that is the best fit.
But Hafiz bhai, before that, actually for the ECG diagnosis, what should we consider first? As because most of the points are in favor of the right ventricular hypertrophy.
So the observation is sinus rhythm, right bundle, left axis, left anterior fascicular block.
Exactly.
But Hafiz bhai,
and the interesting thing, Atahar bhai, in the board exam, if you say this, all are correct, you collect 3 points. The main point is in the clinical diagnosis. The clinical point is, say, 6 or 7 out of 10. So the weight, they are asking you to not only to observe, to come to a conclusion.
Otherwise, the point against RVH is the P wave. P wave does not fit with the right ventricular hypertrophy.
But
yeah, so also this is a very typical board question. Right bundle, left anterior fascicular block with a systolic murmur. And the first thing first is atrial septal defect. Can it be anything else that comes secondary in this kind of situation?
Yes.
So that's all I have. And then I can give it to Professor Awal.
Thank you, sir. Thank you, officer. Now, Dr. Anis is with us. He will show some ECG with his cases. Dr. Anis. Officer, can you stop sharing?
Oh, yeah. Yeah.
Anis, you can go now.
But the problem is that sharing option again gone. Well, the sir, there was a sharing option.
You can leave
Sir,
the
নিচে share screen option টা থাকার কথা স্যার।
But right now it's not there.
আচ্ছা ওরে প্যানেলিস্ট করছো না?
হ্যাঁ হ্যাঁ স্যার, উনি তো প্যানেলিস্টেই আছেন।
প্যানেলিস্ট না হলে তো এখানে দেখাই যেত না।
কিবোর্ডের উপর দিকে একদম বাম পাশে স্কেপ বাটন।
No, it was done while Hafiz sir was presenting. It was there, but when he stopped sharing, then it's gone away.
Leave and join again.
Okay.
Leave the meeting and join again.
Is it now visible?
Not yet.
No.
No.
Did you get the share screen?
No, I'm not getting the button.
It's in the lower panel. There is the green button. Up arrow.
Okay, I'm leaving.
By this time, Hafiz bhai. Hello.
Opportunity is not there.
স্যার এখন পেয়েছেন?
না, স্টিল কিন্তু আমি আবার মানে শেয়ারিং বাটনটা নাই।
আনিস নিচের প্যানেলে
আনিস
জায়গায় সবগুলা ইয়ে আছে।
আনিস
কোশ্চেন এন্ড আনসার, চ্যাট, শেয়ার, রেজ হ্যান্ড, রেকর্ড, ওখানে নাই।
ওইগুলো দেখতে পাচ্ছো? যে কিউ এন্ড কোশ্চেন অ্যানসার, চ্যাট, শেয়ার স্ক্রিন।
No.
You move your mouse on the Zoom window.
আনিস তোমার মোবাইলের হোয়াটসঅ্যাপের ক্যামেরাটা তোমার স্ক্রিনের উপর ধরো না। তোমার মোবাইলের হোয়াটসঅ্যাপের ক্যামেরাটা স্ক্রিনের উপর ধরো।
আনিস কি মোবাইল থেকে না ল্যাপটপ থেকে?
ল্যাপটপ থেকে।
ল্যাপটপে তোমার মাউসটা এই স্ক্রিনের উপরে একটু ঘোরাও, এই জুমের স্ক্রিনের উপর, তাহলে নিচে লোয়ার প্যানেলে এগুলো আসবে।
না, ওখানে আমার
আচ্ছা আনিস তুমি কুইকলি এটা কি রিপুর কাছে পাঠাতে পারো? রিপুর কাছে আছে ইসিটা?
স্যার এটা কি ওইটা? আমার কাছে একটা আছে যেটা হচ্ছে কোশ্চেনটা হচ্ছে 57 ইয়ার্স ওল্ড লেডি নন ডায়াবেটিক, এইটাই কি ওইটা?
না, ওরা হচ্ছে একটা ইয়াং ছেলে। আনিস
স্যার
তোমার ইসিটা কি কুইকলি রিপুর কাছে পাঠাতে পারো?
ওকে, আমি চেষ্টা করতেছি স্যার।
স্যার যদি পাঠান আমি তাহলে শো করতে পারবো।
ওকে
স্যার আমি আমার অ্যাড্রেসটা দিচ্ছি এখনই।
আচ্ছা, আমি একটা $1,000 EKG দিই, যদি দিতে পারি আর কি।
$1,000 means diagnosis হয় নাই।
$1,000 means that রোগী মারা যায় নাই, সেভড হয়েছে।
তারপরে আমি যে ওইদিন দিলাম ওইটা দিব না।
রেডি আছে তোমার?
না ওই যে আপনারা যেটা পাঠাইছি।
ও হ্যাঁ, না ওইটা না, এই
আমারটা দেখতে পাচ্ছেন নাকি স্ক্রিন?
ইয়েস দেখতে পাচ্ছি।
এটার কোনো অপশন নাই, জাস্ট discussion purpose.
Female with lupus and shortness of breath.
Yeah. আমি আমাদের থার্ড ইয়ার ফেলোদেরকে বলছি, for getting this EKG right there is no credit, has to be right.
Hafiz right?
Yeah.
It seems there is electrical alternance or rotation of the axis.
Oh, I just this, you are the big gun.
And probably used pericardial effusion is there.
Yeah, exactly. Is it beautiful EKG, isn't it? That because you can't miss this. And but I, you know, this EKGs, and immediately we did the echo and then the pericardiocentesis. And what is the EKG? What is the diagnosis on this one?
This one,
because I will tell you that this EKG sometimes can fool you, right? This EKG looks like left bundle, right? But actually, this is an EKG with 50 millimeter speed.
Yeah.
So there's another thing we need to think about this. That is, this is the EKG to challenge the fellows. You know, sometimes you know the EKG take when there is a tachycardia, because this patient was going almost like 150, 160. They did a EKG with 50 speed, and they created left bundle.
Screen share করতে পারতেছেন আপনি, হেল্প করতে পারবেন আমাকে?
Look at the marker. The marker is very.
I closed it because they want the screen. Yeah, Wadud, you making a good point.
I always make a point of looking at the marker.
Speed is not seen there. The marker shows you the voltage. Speed is written below.
Distance indicate time, and the length amplitude indicate the voltage.
Yes, yes.
Yeah.
It was very wide. It had 50 millimeter per second.
Yes.
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 That was the Wadud ECG. Also the.
So do you do like a pericardiocentesis, or you send for pericardial window?
We usually do pericardiocentesis.
A lupus patient.
Yeah.
Actually, pericardial window
Pericardial
is
window
for
we
when
prefer if the secretion is the fluid is very thick or pus-like, then window is more.
But for a variety of reasons, we do probably use more pericardial window than pericardiocentesis.
Hafiz bhai,
Yeah.
exotic pericardial effusion আপনি কি দেখেছেন?
Exotic.
Exotic.
মানে really weird.
Weird.
Yeah.
In two patient যেখানে শুধু amlodipine withdraw করার পর তার pericardial effusion recurrent persistent pericardial effusion ভালো হয়ে গেল। এটা কোনো তার কিন্তু তারা স্টেরয়েড পেয়েছে, অ্যান্টিবায়োটিক পেয়েছে, সব পেয়েছে, এবং পেরিকার্ডিয়াল এফিউশন একই রকম। অ্যামলোডিপিন জাস্ট ডাক্তার অ্যান্টিহাইপারটেনসিভ উইথড্র করে দেওয়া হলো, তার পেরিকার্ডিয়াল এফিউশন কমা শুরু হলো।
আমাদের এক্সপেরিয়েন্স এখানে মানে অ্যামলোডিপিনের থেকে রফিক ভাই শিওর দেখছেন যে মাইনক্সিডিল ইউজ is more associated with this pericardial effusion. Yeah, minoxidil. But usually those we don't need to tap. If there is no indication for tamponade, they stop the drug and it probably goes away. Yeah.
So, any sawal?
But importantly, the EKG is, you know why? Because we don't see pericardial tamponade for TAP that often.
So there is the fellows, they fight with each other that who got the patient because they get the first chance. And lately, I'm telling you, it has happened to me that you have gone to RV and then struggle. I don't know how you do it. We usually do the bedside, but in the cath lab, if we are doing a pericardial, drainage tube, if you're planning to live in, then you can send the wire up and then get the tube in, and that fluoro helps. Otherwise, bedside is good enough to do but I usually, this is Morton Kern is very adamant about this part, which is if there is a tamponade, then do not give the injection as you go in to see the bubble, because you want to see the bubble in the pericardial cavity. But his argument is that aspirate first, even if it is blood or you don't know where you are. Because if you're in the pericardial cavity, patient is already tamponade and without draining, you are giving bubble, that may decompensate the patient rapidly.
Sir.
So he says aspirate 20 or 50 first, and then put the bubble. After some nasty experience, I now tried the what they call micropuncture needle, which is actually pretty decent. That you do the micropuncture needle and then see the give a little bubble, see the position is good, and then go with the micropuncture dilator, and then use the wire and get everything under control. So micropuncture sometimes, because if you do harm, you just take it out.
Thank you, sir. I think Dr. Anis has got some technical problem, so we can conclude to this session. It's already 1.5 hours. Wadud, sir, your comment, please.
Actually, today we have some apparently simple ECG, but throwing us into a conundrum, what to say about these particular ECGs. This is very nice. You think you know what is what, but then you find out you don't know. That's the very interesting part and the beauty of ECG. And thank you everybody for joining us together. And I hope again and again, our faculties will show us so-called mundane ECGs, which are actually not mundane, but quite extraordinary in its wider interpretation. And as Hafiz Bhai was saying, you have to have 3 levels: recognize, point out the findings, then interpret what will be the conclusion. That's the 3 things we should be practicing always. Thank you, everybody. Good night.
Thank you, everybody. Good night, everyone. See you in next Saturday. Thank you, Beximco. Thank you, everybody.
Saturday, Toufiq sir are here.
Next Saturday.
But for his presentation, and he missed the rest of the presentation because of technical problem. And thank you, Hafiz sir, for your presentation. And I hope Anisul Awal will be ready for the next time.
Yeah.
Anis?
Firoz,
Yes.
the declaration that is the next Saturday. Our speakers are Rupik sir and the Chowdhury Hafiz. Next Saturday.
So for the attendees, don't miss that session. Don't miss next Saturday session. It will be a mega session. It will be a very good session for us. Try to join at time. Thank you, everybody. Thank you. Good night.
Good night. Assalamualaikum.
Miss Kollam.
Thank you, Rupik. Anis.
Sir.
So, but actually, তুমি কি এখন রেডি হইছো?
না স্যার, আমি তো এটা স্ক্রিন শেয়ার অপশনটাই আসলো না, আমি তো বুঝলাম না স্যার কেন।
আচ্ছা, নো প্রবলেম, তুমি এটা রেডি রাখো, আমরা নেক্সট ডে দিয়া করব।
একটু প্র্যাকটিস করে ফেলো, আর নাইলে তুমি যেটা করবা তোমার প্রেজেন্টেশনটা
রিপোর্ট করে পাঠিয়ে দেবে
অথবা আমাকে।
হ্যাঁ স্যার, আমি মেল আইডিটা দিয়েছি, আমাকে পাঠিয়ে রাখলেই হবে, আমি রেডি।
আচ্ছা, অসুবিধা নেই, নেক্সট ডে এটা ইয়া করলে হবে।
ঠিক আছে।
তো রিভিউ তুমি যে চিঠি দিয়ে দিও স্যারদের।
স্যার দিয়েছি, আরেকবার আমি দিয়ে দিব, সমস্যা নেই।
ঠিক আছে। হ্যাঁ
আতার ভাই,
আচ্ছা,
আতাহার ভাই,
ফাইনালি আমার মনে হয় কারা কারা আছে, আমাদের জামিলকে আমরা কনগ্রাচুলেট করি। জামিল হচ্ছে সঙ্গীত শিল্পী, এখন সরকার স্বীকৃত সঙ্গীত শিল্পী জামিল।
thank you, sir.
করার কথা ছিল তো আজকে এটা।
আচ্ছা, আতাহার ভাই মনতোষ আছে না?
হ্যাঁ,
মনতোষ
মনতোষ পরশুদিন চলে গেছে। আচ্ছা, আমরা ইয়াকে দেখতে পেলাম,
আসছিলেন?
খালিকুজ্জামান।
আমরা জানালেন না তো।
আরে তোমার জানালাম না, তুমি
আপনি বলে পুরো শিডিউল পাঠিয়ে দিবেন আমাকে, আর তো বললেন না।
যাকে অসুবিধা নেই, তুমি আসতে পারতে না, ও চলে গেছে, আবার আসবে হচ্ছে মার্চ মাসে।
আচ্ছা
আচ্ছা, খালিকুজ্জামান, তোমাকে সামনাসামনি কনগ্রাচুলেট করি। এবং আচ্ছা না, তোমাকে সামনাসামনি, আচ্ছা, উই আর ভেরি মাচ রিয়েলি হ্যাপি এবং তোমাকে কনগ্রাচুলেট করছি। আর তোমাকে একটা দায়িত্ব দিচ্ছি, মানে তুমি তোমার ডিপার্টমেন্টের পক্ষ থেকে কিন্তু একজন ইসিজি অফ দ্য উইক, এই মানে তোমার ডিপার্টমেন্ট থেকে অ্যারেঞ্জ করবো। আমরা এই মানে ডিসিশন নিচ্ছি যে এটা মানে আমরা কখনো কখনো কোনো কোনো প্রতিষ্ঠানকে দায়িত্ব দেবো, তার ভিতরে আমি মনে করি যে তুমি, জামিল, সবাই, তো তুমি আমার মনে রেডি হও। সময় ইউর ডিপার্টমেন্ট উইল মানে প্রেজেন্ট ইন এই যে ইসিজি, এই পুরো সেশনটাই তোমাদের হবে।
আচ্ছা আচ্ছা, ঠিক আছে স্যার, ঠিক আছে।
আমারও কিছু দিচ্ছেন নাকি দায়িত্ব আছে?
হ্যাঁ, তোমাকেও দেওয়া হবে। তা আমার মনে হয় তুমি রেডি হতে থাকো জামিল। তোমাকে এবার অ্যাডাল্টে নিয়ে আসা হবে, তোমাকে পিডিয়াট্রিক্স বাদ।
জি, আগে তো বলেন।
তো ঠিক আছে, থ্যাংক ইউ এভরিবডি।
আসসালামু আলাইকুম স্যার।
আসসালামু আলাইকুম, গুড নাইট।
গুড নাইট।